we have a fantastic session planned today. I'll keep our intro very, very short so that we can maximize the time with our two guest speakers today. But we got some real cool stuff planned for y'all. So thanks again for jumping on, spending the time. Real quick housekeeping before we get rolling today. Our chat is up and running, thanks to those that have already started to use it. If you've got a question as we go, drop it in there. It will go right to our speakers and presenters today. So if we get a chance, we certainly want to keep it interactive and answer questions on the fly as well. We will save time at the end to get to questions, but inevitably, we with time being what it is, we'll run out of time. But we'll make sure if you drop a question in the chat, we will get it answered, and we'll at least certainly get it routed to the right person as well. So please feel free to drop in questions as we go. And the last thing is you will get a copy. This is being recorded, so you'll get a copy of the recording. And we've got something special to send to y'all at the end of the session as well from both of our companies. So you'll get all of that via email later this afternoon. So without that, we'll go ahead and kick it off. We have a really, really interesting topic today. Just a Medicare policy update using new anti-kickback safe harbors to maximize opportunity. And we are joined by two incredible speakers from Strategic Health Law, and we'll talk a little bit about who they are and what they do in just a second. If you haven't been to a webinar with us before, a quick overview of who Provider Trust is. We are made with love in Nashville, Tennessee. We're a compliance, we're a data and technology company that focuses in compliance, based in Nashville, Tennessee. And so we like to say insights from America's healthcare capital. We believe pretty deeply that a smarter healthcare makes a safer healthcare. And a little bit about us is just everything from license verification to OIG exclusion checks to everything in between. Our goal is to deliver a really powerful platform that can help enable total enterprise compliance across your organization. Just a little bit about what we do. So we spend all day living in the world of compliance and policy and procedure to make sure that we can really understand and deliver value to each of you on the phone today. And our speakers, and then we'll pause the slides and give you a chance to let them introduce themselves. We have just two fantastic guests joining us today, Elizabeth and Sandra from Strategic Health Law, who just live and breathe Medicare policy, helping our payer friends and certainly providers as well, just navigate, understand how to maximize regulation for business opportunity, interpret the new policy, and they're really truly subject matter experts on what we're about to go through today. So to save time, I'm going to I'll kick us off with our first question. I'll go ahead and stop sharing so you can see us big and bold today. But our first question, Sandra and Elizabeth, just go ahead, introduce yourself, a little bit of background, and tell us a little bit about what y'all do at Strategic Health Law.
Yeah, thanks, David. I'm Elizabeth, and I founded Strategic Health Law back in late 2005 after spending 5 years in-house at a health plan and working on the implementation of Medicare Part D, and really realizing that Medicare Advantage and Medicare Part D were big, highly regulated programs that there were probably a lot of plans that would want to work with me. So that's what we focus on.
And I'm Sandra Durkin. I've been with Strategic Health Law for about 2.5 years. My background prior to joining was as a litigator with a history of representing companies, including plans in high stakes disputes. These days with Strategic, we counsel health plans, managed care companies, and their vendors in the government space to help avoid getting into litigation and compliance and enforcement situations in the first place.
Awesome. Thank you both for being here. Let's just get right into it. So tell us a little bit about what is the federal anti-kickback statute? When was it enacted? What does it prohibit? Just give us a little bit of background.
Yeah, for sure. The anti-kickback statute is a federal criminal fraud law, and it makes it a crime to offer, pay, solicit, or receive anything of value that's directly or indirectly to induce referrals of services or items that are going to be reimbursed by a federal healthcare program, so like Medicare, Medicaid. And it was passed in 1972. And if you think about what was happening in the healthcare world, I mean, everything was fee for service pretty much at that point. So the law was passed so that, a doctor's practice wasn't referring everything to one particular lab or something else just to get a kickback, that they were making healthcare decisions based on the patient's best interest. But you can see how this would impede things like managed care, which wasn't really on anyone's mind in 1972. So in 1991, the first set of safe harbors came out, saying, certain things that you want to do for good reasons in healthcare, like have discounts to be in a managed care organization's network, those fit in a safe harbor if you meet certain requirements. So those, even though they otherwise would be considered an anti-kickback violation, they're not, because we want you to do that kind of thing. So that's the background.
So then talk to us a little bit about why is it such a big area of risk, and do all sort of plan and provider arrangements have to fit one of these safe harbors? Yeah,
so it's a big risk because of the how serious the penalties are, and the fact that they're, even for individuals, there can be criminal, like jail time. So it's a very serious law. But it also governs, it's so broad, it catches things that are perfectly legitimate and ethical to be doing. So that's why you have to look at these safe harbors. Now, it's not mandatory that every healthcare transaction fit in a safe harbor, but it certainly offers protection. And I know if I were leading a healthcare company, it would be very important to me to see either to get squarely into a safe harbor or to be as close as possible and have good reasons why maybe some of the line items in the safe harbor weren't met.
And so that's super helpful. Let's talk background for a second, and go back and say, prior to new safe harbors, how did health plans or organizations manage any kickback risk prior to these new safe harbors? And maybe Sandy, that one might be a good one for you.
Absolutely. As Elizabeth mentioned, there's a whole laundry list of safe harbors that predate the 2020 updates. OIG has been issuing them since 1991 to protect common business arrangements. One of the most important one for health plans and our clients is the managed care safe harbor. This is the most flexible safe harbor for eligible managed care organizations, a group that does include Medicare Advantage plan sponsors. And what it does is it protects payments between the managed care organization and first-tier contractors, as well as downstream arrangements. It's a broad safe harbor. It'll cover a variety of payment arrangements, discounts, payments based on volume, quality. However, there are some limitations. And one of them is that there can't be any payment for referrals of federally reimbursable items and services other than those spelled out in the contract. And if you're not fitting into this safe harbor or one of the other safe harbors, health plans really did need to do a risk assessment. And there's a couple of ways our clients do that. They can submit advisory opinion requests to OIG, or they can, if you're in the value-based world, just weigh the risks and the benefits of entering into an arrangement. And that's why these new safe harbors are something that the industry was really looking forward to.
Mm-hmm. And so how then those new safe harbor arrangements or the new safe harbors, how do they impact anything existing?
That's a really good question. If you work for a plan or a provider organization, we certainly expect that you will be asking, do I need to go back and reevaluate all of my contracts that were designed with pre-existing safe harbors in mind? We like to offer a concrete example. Say you're an MA plan that reimburses providers on a fee-for-service basis, and you pay bonuses to providers that meet criteria tied to star ratings, and your contracts rely on the pre-existing managed care safe harbor. Does the plan need to amend its bonus arrangements? The answer is no. Arrangements that were designed to fit into the pre-existing safe harbors may continue to rely on them.
Okay, super, super helpful. Elizabeth, wanted to ask you, just comment, and we look at the updates, we look at where we are today, very broadly, 40,000 feet, given our audience is varied today from, we have a large chunk of our audience in compliance, but we certainly have folks from other areas across healthcare as well. what are the common themes in these updates, and why are they significant? So maybe leveling up 40,000 feet, just this is the $1 million question of what do the folks on the phone need to know about these common themes, what's new, and why they're so significant?
Yeah, I would say the significance first is that, well, just practical doing our job significance for those of us who are healthcare lawyers or compliance professionals, some proposals that our internal clients or business people would have come to us with a year ago, we would have had to say, ooh, don't do that. That's really going to be super high risk, if not like totally illegal.
Mhm.
Now there might be a way to do it. So it's really good news. It's going to be a lot of work to understand what business people want to do and to improve healthcare delivery and efficiency and quality, and to figure out how to get it into these safe harbors. But it really is a great opportunity for the healthcare industry. Some things that some areas, broad areas of more flexibility. You could tell the drafters of these regulations understood the need for digital healthcare technologies, both things to help patients be healthier and to get those to patients, but also things to help integrate care with a lot of different players. So you've got, say you have a clinically integrated delivery network or like an ACO type arrangement that includes maybe a health plan, a large health system, some smaller players, maybe a home health agency that doesn't have the same resources, provider groups. So big and small. A common obstacle is these small organizations can't always afford the electronic health records or the digital technologies to participate in that. This helps get that value to them so that you can expand the players in your enterprise. Another thing is that they really left it up. They didn't prescribe exactly how you need to do things. They said, here are parameters, here are requirements you need to meet, but it leaves it to the industry. And this is great, but it's also a challenge to figure out, okay, what do we want to do that we weren't able to do before? And then to work with your compliance and legal teams to figure out how to achieve what you want in a way that fits with the regs.
Yeah, that's super helpful. So helpful context at a 40,000 foot level. And then maybe Sandy, if we dig down into maybe a more tactical level as well, is just what can you give some specific examples? And Elizabeth already gave a few, but maybe one or two more specific examples of new arrangements that would be protected or could be protected in theory by these new safe harbors. And then maybe a part two is, are there types of entities that maybe aren't eligible for protection? Where in some of these updates, does it go that deep into type of entity? And would love if you can maybe shed some light on that.
Yeah, absolutely. So taking the first question, some examples of new arrangements. We couldn't possibly talk about all the possible arrangements today. There are 7 brand new safe harbors, 4 modified safe harbors. They all are designed to protect different things. But to give some examples, there is a modified safe harbor that protects payments based on achieving health outcomes. So what this could protect is bonuses that are tied to actual outcomes measures. Say you have a bonus payment that's tied to a certain number of patients with diabetes having their blood pressure tested. That would potentially be eligible for protection. There's also a new safe harbor that protects in-kind transfers of value, so non-cash payments that are used specifically to coordinate care. An example of this would be a skilled nursing facility could provide a hospital with staff to assist in coordinating patient care through the inpatient discharge process. And then there are also 2 new safe harbors that protect value-based arrangements where parties start to take on downside risk from a payer. So you could get shared savings or losses arrangements or fully capitated payment arrangements. And to move to your second question, are there any entities that cannot rely on these value-based safe harbors? And unfortunately, I don't know who is all on the phone, but the answer is yes. There is a list of ineligible entities. It includes drug manufacturers, PBMs, labs, compounding pharmacies, and a few other types of organizations. And really, the reason is that OIG has decided that these entities present some heightened fraud and abuse risks, and they are on the front lines of care coordination. We like to make a quick note for our payer clients. Payers are eligible for protection even if they own or are affiliated with a PBM, which is a common arrangement.
Okay, super helpful. So, maybe shifting gears a little bit. I think it was Elizabeth that may have touched on this as we first started this conversation, but questions on how do the new safe harbors encourage the transition to value-based care? What are, VBEs, value-based enterprises? What could the structure of one look like? Again, just kind of playing out the hypothetical. I know we touched on value-based care very early in the conversation, but Sandy, maybe let's take that to a bit of a deeper level.
Yeah, happy to. The way that these value-based safe harbors actually facilitate the transition is by offering incentives to providers and other entities to take on risk that would traditionally be borne by a payer. And the way they do that is the parties have more flexibility in their contracting arrangements as they take on more risk. So just to give you an example, I talked about the care coordination safe harbor, which does not require anybody to take on downside risk, but it only protects in-kind non-cash transfers of value, and there is a commercial reasonableness requirement. But as parties start to take on downside risk, you get a little more freedom. Your payments can be not limited to in-kind. There are no commercial reasonableness or fair market value requirements. And this is really important, but you can start to make payments that take into account referrals, as long as those referrals are within the target patient population and to other entities that are participating in your value-based enterprise. And this really makes sense because providers who are on the hook for cost of care have fewer incentives to order unnecessary items and services.
Yeah, it makes a lot of sense. So along those lines too, can entities provide incentives directly to patients under these new safe harbors?
Yeah, that's a good question. The answer is absolutely. There is a safe harbor that protects the transfer of items and services directly to patients. And there's a limited pathway there for medical device and supply manufacturers to provide those items and services as long as they're digital health technology and meet the requirements. And I think that's significant because the anti-kickback statute and its companion regulations have traditionally precluded those transfers of value to patients, except for some limited exceptions. And I do want to back up because I think I missed one of your questions. You had asked about value-based enterprises and what could the structure of a value-based enterprise look like. That's getting a little bit down into the nitty-gritty, but it's important context because the value-based safe harbors do specifically offer protection to parties to a value-based enterprise. Value-based enterprise, that's the lingo that OIG has used. It's a pretty simple concept. It's just two parties working together to achieve a value-based purpose, such as coordinating care, improving quality, reducing costs. And there's only a couple of operational requirements. And it's that you need to have an accountable body and you need to have a governing document. So you don't need to set up a separate legal entity for your value-based enterprise. You can set it up with a contract.
And I would also add just to that, it can be really simple. It could be two parties, two healthcare provider entities, a plan and a provider, or it could be a larger group that includes a lot of different players. And then it could be a much more complex value-based enterprise. So there's a big range of what healthcare industry participants could come together and do under these new flexibilities.
Yeah, thanks for that context. I wanted to circle back real quick to the last question, which is just, can entities provide incentives directly to patients under these new safe harbors? For those, there's a lot of folks that are in the nitty gritty of this and work in compliance every day and are paying really close attention. For the folks that maybe are in HR, we have several folks that are in HR leadership or other executive leadership out that maybe aren't super familiar. Is that actually a change with these new updates, or was that in place before? How has that evolved with some of these updates?
I'd say it's an expansion. There have been limited contexts where that was okay. For example, with a Medicare Advantage plans, patient incentive programs, but this expands it and expands the abilities of providers to deliver those types of things. And Sandy, you could add to that.
Yeah, I was going to say, traditionally we might have looked at 2 exceptions for nominal gifts, which could be provided to patients, but that's got a cap at $75 a year, I believe. And the cap for incentives provided under the safe harbor is considerably higher. It can go up to $500 per year. And it's not limited in the type of item and service. As long as it's serving a purpose that's contemplated by the safe harbor, it can be something like grab bars or rails in a patient's home, or it could be technology that helps track and monitor health.
Yeah. And if you want to think about it in practical terms, like 1972 to now, like in 1972, if you were giving something nice and useful to your patients for free, the concern would be you're trying to it's like a kickback to get them to keep coming to you. Here, there's a recognition that that doctor or whoever is giving that to the patient is on the hook for the financial cost of their healthcare at some level. Yeah. So they're all in it together, and their motivations are pure under the law to want to give that tool to their patient.
Yeah, helpful. So shifting gears a little bit, Elizabeth, to you, what would you recommend strategically for a healthcare organization that wants to take advantage of these new safe harbors? And keep in mind that there's folks on the phone that are probably hearing some of this for the first time. There's folks on the phone that potentially are in this every day. But what's the first step if you want to take advantage of some of these things? What's step one?
Yeah, I would get the right people in your organization thinking about it, kind of the right people at the table with some input from your legal advisors and compliance advisors, and then your medical directors and people that are on the front lines, as well as some of your strategic thinkers and business strategists. And then think about what are the pain points, what are needs, gaps where we're not seeing the results of our efforts so far in terms of care delivery and incentivizing value-based care, and target a program. Just get the right minds in there, and don't go to your lawyers and say, what can we do? Because we're not the best strategists for your business. Think about care delivery. What do you want to improve? And then bring in advisors to help you do that. And then as you think about who to partner with, and I use that not in a legal sense, but the other organizations you'd like to bring into a value-based entity or enterprise, I would think about who you've had good working relationships with before. Because especially with payers and providers, those can be tough relationships if for decades you've been basically fighting over money. And now you want to come together in value-based arrangements and collaborate and partner together to improve things. So I would think carefully about who you think in your orbit is going to be able to make that transition effectively, so that your first endeavor under these new flexibilities is successful.
Yeah, really helpful. I'll close with a final question, and then we did have several questions come in as well from those listening in. So we'll give the last 2 or 3 minutes on the phone just some space for y'all to field some questions from folks that are listening and are really interested. But before we get there, I really wanted to ask about just the difference in administrations. And so, Sandy, to you, these regulations came out at the end of the last administration, and we've got a new one that's going to enforce them. So I'm just, what are your thoughts on enforcement, risk, and climate? What have we seen? What would we might anticipate? I know this is a crystal ball type of question, and what do we think is going to happen versus what have we seen, because we've got a relatively new administration. But just curious what y'all's thoughts are, just given the differences in administration and enforcement.
Thanks, David. Though these regulations were issued under the previous administration at the tail end, they did have broad support, and they were really anticipated by the industry. And we would say, long overdue. Biden administration did have a chance to hit pause and look at regulations that came out at the end of the previous administration. And this is not one of the regulations that they chose to hit pause on. These are here to stay. And we do believe there's a potential for increased enforcement under the new administration. It's still a little bit early to tell because, as Elizabeth said, these regulations expanded the box for healthcare organizations to deliver care. They didn't create a whole new list of rules that you need to follow. So what we need to do is wait for the industry to start implementing new arrangements to get a sense of how OIG will respond to them. And of course, we appreciate that many organizations, especially providers, are still incredibly focused on COVID, as are the agencies. But we are watching, waiting for OIG to issue advisory opinions on these. And in the meantime, we think there are strategic advantages for organizations that see the opportunity in the new way of contracting that's contemplated by these safe harbors to move towards a value-based care system.
Yeah, that's helpful context. So appreciate y'all taking us through that. We do have a couple of questions in our last 3 minutes here, which to the best we can, let's see if we can tackle them. The first one is from Marcy had reached out when we were talking about can entities provide incentives directly to patients under the safe harbors, and just asked about if would that under any circumstance include vaccine incentives as well. And I know that this is certainly a hot topic at the moment. I'm curious whether or not, certainly there's all kinds of context that goes into a question like that for sure. But curious if any of that has crossed y'all's desks as folks within the context of safe harbors. Has that come up at all?
That hasn't crossed our desk specifically, but off the top of my head, I can't think of a reason why you couldn't craft an arrangement that would fit and use it for incentivizing vaccines. Now, we won't have time today to go through the detailed analysis, but I think that's an idea worth exploring.
Yeah, helpful. And then we had one question come in from David as well. And I'll read it. It's a little lengthy, so I'll read it. And I know Sandy and Elizabeth, y'all can pull this up too. I believe you can see him if you want to. But David's saying, he works for a physician staffing company. He has a 1099 that works for us in the ED, but also works as a hospitalist in the same site and actually does skilled nursing facility work as well. So technically, he can refer a patient to himself at any level. Does this meet any type of value-based exception, or does this relationship present a potential exposure? And certainly, of course, there's all kinds of context that goes into that, but curious what y'all's thoughts are when you hear that come in.
I don't think we'll be able to take that one on the fly. It's a good question. It sounds like a conscientious business person's asking the right questions, but that's going to take a pretty detailed review.
And I would also add, we have not talked about today the Stark law, because this is a physician situation. You do have to look at the Stark self-referral law, and there were updates that were issued at the same time as these safe harbor updates that we're talking about today. So potentially there could be something there that applies, but that would require a somewhat detailed
deeper
analysis.
dive. For sure. Super helpful. In our last 60 seconds here, just wanted to say one more time, Elizabeth and Sandy, thank you all for sharing your knowledge and wisdom with certainly our audience today. A few just immediate next steps, if you're listening in on the phone, we have both of us, Provider Trust and Strategic Health Law, put together essentially a one-page overview and checklist of here's a couple of first steps. Y'all, when we send out the recording today, y'all will get that. It's a great piece of content that we just wanted to make this really tangible and tactable in a day one type of exercise. So be on the lookout for that. When we send the follow-up to each of you today, we'll be sure to include a little bit more detail and info about strategic health law and how they help organizations manage some of this as well. And if you've got a particular circumstance or question that y'all are interested in, or potentially even interested in bringing them on as partners as well, would fully encourage y'all to reach out. We think the world of them and their organization and what they do. And so just please feel free. You'll get their contact information today. So if there's a question that you had but didn't quite get time to ask, or we haven't been able to answer, please feel free to reach out to them directly and start a relationship. Sandy and Elizabeth, this has been amazing. Thank you so much for the time.
Thanks for having us.
Yeah, absolutely. And for those who want to share this, you'll get the recording today, and it'll also live on our website, providertrust.com, along with our content. So if you're ever looking to come back and revisit this conversation, please feel free to do so. It'll live on there. Thanks everyone for
Thanks,
the
David.
time. Enjoy the rest of your afternoon or morning, depending on where you're at. And if you've got any questions, feel free to let us know.